Hello, everyone, and welcome to another edition of Contagion. My name is John Parkinson, and I'm the senior editor. Joining us today is Dr. Jonathan Volk, who is an infectious disease clinician who treats patients with HIV at Kaiser Permanente San Francisco Medical Center. Dr. Volk is board certified in infectious disease. Thank you, doctor, for being able to join us today.
My pleasure.
Let's jump right into the topic. For those not familiar with your research on the PrEP continuum of care and new HIV infections, can you provide an overview of the study and your findings?
Certainly. Yeah, we really wanted to understand the PrEP continuum of care from linkage to care onward. So we know that once patients are linked to PrEP care, there's multiple additional steps that people need to go through to be able to use PrEP effectively. People need to receive a prescription for PrEP, they need to fill that prescription, and they need to stay on PrEP throughout periods of risk. We looked at all of our patients at Kaiser Permanente in Northern California who were linked to PrEP care from July 2012, when PrEP was first FDA approved, through March of 2019 to allow enough time for follow-up, and looked at the continuum of care to better understand opportunities for improvement in PrEP delivery. What we found is that the majority of patients who were linked to care did receive a prescription for PrEP, and most stayed on PrEP and were persistent for up to 5 years on treatment. When we did have drop-off in the PrEP continuum and people were lost to follow-up, it was primarily in that first year of follow-up. After 1 year of treatment, most people maintained and stayed on the medication.
It's noted in the study that many patients do not complete key steps in PrEP continuum of care, resulting in preventable HIV infections. Are there any particular steps where this happens more frequently?
Yeah, I think, again, it was very important that we describe incident infections throughout the continuum, as you noted. And there really were two key steps where we lost folks on the continuum, and we had preventable HIV infections that we observed. The first were people who were linked to care. So they had a PrEP referral or a clinical encounter where PrEP was discussed, but never received a prescription. So there was that first encounter, but the prescription was never written for a patient to fill. The second was among patients who were linked to care, started on treatment, but later stopped. And so both those groups, we observed more than 1% incidence of HIV infection during the study follow-up period, really highlighting opportunities for improvement.
Okay. And looking at the African American population, this patient group was less likely to get a prescription, less likely to initiate PrEP, more likely to discontinue PrEP. Do we know why, and are there any strategies to overcome these challenges?
I mean, there's several, and I think it's certainly something that we've observed and has been observed in other settings as well, and I think is a big challenge for us in PrEP delivery and something that we need to be very aware of. I think there are several different things that we're doing to address that disparity. One, I think a big one is the cost of the medication, and that's both actual cost and perceived cost of PrEP treatment. PrEP received this last year a grade A recommendation from the US Preventive Services Task Force. And because of that, we are now able to offer PrEP free of charge for pretty much all of our patients. So increasing awareness of that among our population will hopefully reduce one primary barrier that we might see to PrEP uptake. Another thing that we're doing, which I think has been sped up because of what's happened in the world over the last few months with COVID, is really a move towards a lot of virtual care and meeting patients where they're at. And so for some patients, it may be hard to get in for a clinic visit to start PrEP. And so we're doing a lot of PrEP initiation and most all of our follow-up virtually, so by telephone or video, by secure email messages, hoping to facilitate initiation of PrEP for patients who might not otherwise get into clinic. Something else that I think we're really doing that I think is important is trying to identify people even further upstream from linkage to care. So these are patients who may be candidates for PrEP or who could benefit from PrEP, but are not being linked to care. One of the other projects that our group has worked on is an HIV prediction model. We know that when we rely on the kind of traditionally thought of risk factors for HIV, things like being a man who has sex with men or recent sexually transmitted infections, we actually underestimate risk, particularly among our Black men who have sex with men. And so we wanted to know if we could leverage our electronic medical records to build a more kind of robust prediction model to identify potential candidates for PrEP. And so we use the model with over 40 different variables that include demographics like age and gender, social history variables, lab variables such as testing for STIs or STI positivity, medications like those for erectile dysfunction meds or treatment with penicillin after a positive syphilis test or getting a syphilis test, and diagnoses like mental health diagnoses or anal wart diagnoses. And what we found is that the final model included over 40 variables, and we were able to prospectively identify about 50% of our incident infections in our male patients by flagging the top 1 or 2% of risk scores in our population. And one of the things that was very exciting for us is this model performed equally well for our Black patients as our white patients in terms of predicting HIV risk to help address some of those disparities. So one of the projects that we're working right now is to implement this prediction model in a primary care setting. So to help facilitate discussions between primary care doctors and their patients about sexual health and HIV risk and linkage to care when appropriate for PrEP.
Wow, that's exciting news. You'll have to
Very
keep us posted on that.
Yeah, it's a novel way of us trying to kind of address that disparity that we're seeing, and is really a priority for our group.
And obviously, you're going forth with this particular information and trying to roll it out in primary care. And where else, doctor, do you think we're going with the knowledge from the study that might be applicable?
Yeah, I mean, I think, again, one of the other findings that I had not mentioned before, but I think is an important one, is we now have 13,000 person years of follow-up among our patients on PrEP. So a huge amount of follow-up. And we have seen 0 new infections among patients who are using the medication consistently. And so I think really the question of how effective PrEP is has really been asked and answered by us and others at this point. We also have very compelling data about the safety of this medication from our work that we've done and others as well. And so the question is really now, how do we link people to care who could benefit from PrEP and help people move through the continuum? People who are seeing for PrEP who might not pick up a prescription, or people who are on PrEP and then later stop. One of the other things that we are doing, and we've been able to kind of leverage our population management tools that we've developed internally here at Kaiser Permanente, is we can now reach out to people who are on PrEP and subsequently stop. We have a way of identifying those individuals so that we can periodically check back in with people through secure email messages or phone calls to ask the question if PrEP may still be right for them, recognizing that people's risk for HIV can change over time, and that PrEP may not make sense today, but it may make sense in a month or in 6 months or in a year. And we want to be able to hook those patients back into care if their risk for HIV is continuing. I think also our work really highlights that an emphasis of our adherence support really needs to be in that first year of treatment. We see the largest drop off, so 27% drop off in that first year of PrEP use. And so really helping people during that first year maintain on PrEP if risk for HIV is continuing. After people have been on PrEP for 2, 3, 4, 5 years, drop off is very low.
It's an interesting fact that you're looking at more of a drop off in year 1 as opposed to what might be something where people might think that as you go on, that you might have more of a drop off in year 3, 4, 5, something like that. But it's something that it's really become habit forming for those folks, it sounds like, who are on PrEP longer than.
Yeah, and I mean, it's also worth acknowledging this is observational data from kind of real world clinical practice. And certainly the patients who started PrEP 3, 4, 5 years ago might be different than the patients that are starting, who are starting PrEP today. And so, certainly back in 2012, 2013, a lot of those individuals who are starting PrEP were people who were very aware of PrEP, many of whom were knocking on our door the first day it was approved by the FDA. Some of these individuals may have participated in clinical trials of PrEP before it was FDA approved. And so there may be some differences in the patient population as well. Though certainly we do expect some drop off. People may be single and then enter a monogamous relationship where it makes sense to stop PrEP for a period of time. That relationship may end, and then it may make sense to resume taking PrEP again. And so trying to match PrEP to periods of people's life where it could benefit them is really our challenge.
And changing gears and looking at the big picture perspective, what would you say are the biggest areas of unmet HIV medical therapy needs?
It's a big question, and certainly I think there's a lot of areas from treatment for folks with lots of background resistance to having more HIV regimens with fewer side effects, addressing stigma, reaching populations that may not be diagnosed with HIV. In terms of kind of one piece of that puzzle, I think is the HIV prevention piece, and I think we've talked a little bit already about really trying to address the disparities that we're seeing in PrEP uptake and in drop off along the PrEP continuum, and where we are seeing a disproportionate burden of this disease. So in particular among our Black men who have sex with men, our adolescents, our transgender population, trying to figure out how we can engage communities both locally and around the world to really improve uptake and penetrance of a strategy that we know works incredibly well.
And lastly, with the state of affairs today with the COVID-19 pandemic, we are having to do conferences virtually. Can you talk about some of the benefits and challenges associated with doing it this way?
Yeah, it's a brave new world for all of us. I think one of the clear benefits is there are many people who I am sure are being able to access this conference and this meeting who otherwise would not have been able to get to San Francisco or Oakland to attend the conference in person. And really, that's fabulous that we're having more people who are able to participate who otherwise might not be able to. And I think the challenge obviously is keeping the camaraderie of the meeting and the energy of the meeting, of getting folks who are all working on the same problems from around the world together, talking, brainstorming, building those collaborations. And so that's, I know there's a lot of work being done in that meeting to make sure those conversations are happening, but that's certainly a challenge. I think much like this meeting going virtual, I think it's also changed our thinking in terms of HIV care and PrEP care as well, in terms of using these virtual platforms to deliver medicine and to take care of our patients. So in addition to kind of the research world and the dissemination of our findings, recognizing that a lot of the work that we're doing now in terms of getting people started on PrEP, providing adherence support, reaching out to people who may have discontinued PrEP, can be done using technology like video visits and telephone visits to really expand our outreach.
Absolutely. Doctor, thank you for taking the time today to discuss this important research.
My pleasure. Thank you.